Hello, everyone. My name is Dr. Rudrani Banik, and I'm a neuro-ophthalmologist. I wanted to thank Real World Ophthalmology for inviting me to give this talk today on neuro-ophthalmic diagnoses not to miss. So just a little bit of background about myself. I'm fellowship trained in neuro-ophthalmology. I currently work in New York City. I have a hybrid practice. So I have an academic appointment with New York Eye and Ear Infirmary of Mount Sinai, where I teach there, I do my research there, but I also have a private practice where I see patients in my office. I see neuro-ophthalmic conditions, I see patients with migraine, and I also see some comprehensive ophthalmology as well. Again, thank you for having me do this talk. And what I'm going to walk you through today are 4 neuro-ophthalmic diagnoses that you do not want to miss. These are conditions that could be potentially vision-threatening or life-threatening. And these are conditions that may walk through your door or that may show up in an exam, whether it be your board exam, your written or your oral boards, or even OCAPs. Definitely, these are conditions that will show up on there. So you should be very familiar with them. Now, I have quite a lot of experience in teaching neuro-ophthalmology for board review, for exam review. For example, I've taught the Osler course for many years. I've done their neuro sections and done mock oral exams. I also have subsequently been asked to be on the American Board of Ophthalmology's exam development committee. So I've written questions for the board exam, for the oral exam, and for the OCAPs. So I have a lot of experience with this, but these are, some high yield questions or high yield cases that I'm going to go through. So let me share my screen so we can get started, and then you can get comfortable with some neuro-ophthalmology. So first of all, when people, doctors, ophthalmologists see a case that may be a potential neuro-ophthalmic case, this is usually the response many people have is, oh my goodness, I don't know what to do with this patient. This patient has some really suspicious symptoms or signs, and maybe there's something serious going on. What do I do? So I want to take you from having this response to having this response, where you really feel like you are comfortable, you're confident, you know what to do. And I want to help you become an honorary neuro-ophthalmologist, at least for the cases that you're seeing, again, whether it's in your office, whether it's on call, or whether this is, again, in the setting of an exam. So let's start with case number 1. This is an 82-year-old female. She's had a headache for 3 weeks, and her past medical history, she has high blood pressure. And then a review of symptoms, she's been complaining of malaise, anorexia for 2 months, and a 10-pound weight loss. And then she's developed some ocular symptoms that brought her in to see the ophthalmologist. She has a veil that obstructs the top half of her vision in the right eye. And these symptoms are intermittent. They last about 20 to 30 minutes, and then they resolve, but she keeps getting them. She's had a couple of episodes in the past few months. And so in terms of the diagnosis, you're about to examine her, but you have some things running through your mind about what this could be. Of course, you're worried about amaurosis. Could this be some kind of thromboembolus? But you happen to notice this on her exam as you're about to put her in the slit lamp. So you ask her about this, and she says, yes, doctor, it's really quite tender. It's really, I can't touch it. My whole head starts to hurt. And when you try to palpate, you hardly feel a pulse. And she actually jumps back when you first touch her because it's so painful. So of course, what you're concerned about is giant cell arteritis. So how do you work this patient up? Well, of course, you want to do your exam, make sure everything's okay with regards to her retina, her optic nerve, but you want to get some blood work. You want to get a CBC, an ESR, a CRP, and then ultimately, if you're really suspicious, you want to send her for a temporal artery biopsy. So just a few comments about temporal arteritis. This is a systemic vasculitis. It's not just affecting the temporal artery. So I really prefer that you use the term giant cell arteritis. It does carry a higher risk for vision loss from either retinal artery occlusion, whether it's a CRAO or BRAO. Also, these patients are at risk for AION or arteritic anterior ischemic optic neuropathy, but they're also at risk for other types of ischemia to other organ systems. For example, they were at higher risk for stroke, as well as myocardial infarction, as well as kidney infarction as well. So these patients, they tend to be older, above the age of 70. Very rarely do you see GCA in people under the age of 55, and it's more common in women than men with a 3-to-1 ratio. And which type of vessels does giant cell arteritis affect? Well, it tends to affect medium-sized arteries containing an elastic lamina, and it's a granulomatous type of inflammation. And eventually the inflammation causes the vessel wall to thicken and swell, and eventually the lumen becomes becomes occluded, leading to the ischemia. Larger vessels can be affected as well. For example, GCA can also affect the aorta, so keep that in mind. And just be familiar with the histopathology, because they love to have this question on exams. What does it look like? So there's actually cellular infiltration of the vessel wall, the media, as well as the intima is affected. You have a mixed cellular infiltrate, so T helper cells, lymphocytes, plasma cells, macrophages, histiocytes, giant cells, eosinophils, fibroblasts can all be seen. But here you see the lumen is very, very small. So you're going to be looking for this. And also keep this in mind on histopathology, giant cells are not essential for the diagnosis. You're looking for breaks in the internal elastic lamina, as well as a cellular infiltration of the vessel wall. So when you do a biopsy, make sure you're looking at least 2 centimeters of a specimen, because you can have skip lesions that may lead to a false negative biopsy. And also keep this in mind, up to 1/3 of patients with GCA may actually have a negative biopsy, so a false negative biopsy, and you're going to treat them anyway if you're suspicious for GCA. Now, the symptoms, be aware of the symptoms. There are systemic symptoms as well as ocular symptoms. So weight loss, fever, chills, malaise, myalgias, anorexia. And in terms of visual symptoms, amaurosis, as what our patient had, double vision from ischemia to the extraocular muscles, jaw claudication, headache, scalp tenderness, alopecia. These are all potential symptoms of giant cell arteritis. And of course, you want to look for an enlarged temporal artery, a tender artery with a poor pulse. And unfortunately, if patients actually have vision loss, you may have loss of vision from either arterial occlusion, like here we see a central retinal artery occlusion. So any patient with CRAO in that age group, you need to order giant cell arteritis labs for them. And also BRAOs, you need to order GCA labs for them. And remember, it could be either CRAO or BRAO. In terms of AION, usually these patients, the classic appearance is a chalky white looking nerve with edema. And unlike NAION, in which the other eye will have a small cup to disc ratio, usually the other eye has a normal cup to disc ratio or even enlarged. You may sometimes see around the nerve some hemorrhages or even cotton wool spots with AION. And sometimes you'll see the two pictures combined. You may see a CRAO with an AION. So that can happen as well with giant cell arteritis. Eventually, over time, the nerve becomes atrophic. So you'll see like a really white, pale nerve with very attenuated vessels. So in terms of labs, keep in mind that you have to adjust the ESR for the age and sex of the patient. So the calculations are here. For CRP, look at the units. So if it's deciliters, if it's milligrams per deciliter, anything above 2.45 is significant. If it's milligrams per liter, then it's 24.5. So always look at your units when you're looking at GCA labs. In terms of the CBC, you may see an anemia, normocytic, normochromic anemia with a high platelet count, or thrombocytosis with platelets above 400,000 or 450,000. So of course, we treat these patients urgently. Go ahead, start them on steroids even before the labs come back. If you're really suspicious, you do not want to risk this patient not being treated if they may have GCA. And of course, if you start the steroids, if everything comes back negative, you can always stop the steroids. And we usually start with oral steroids if there's no vision loss. If there's already vision loss or ischemia to an end organ, you want to give IV steroids. Don't forget GI prophylaxis, and you do need to order that temporal artery biopsy. In terms of treatment, again, steroids long-term are usually needed, and you want to follow this patient with their primary care doctor and or a rheumatologist, and consider steroid-sparing agents now that we have tocilizumab, which is Actemra. It's a biologic IL-6 antagonist, which is FDA approved for GCA management as well. Otherwise, other immunosuppressants can be used, for example, methotrexate. So now let's move on to case number 2. I know that was a whirlwind, but I need to go fast because there's a lot of information I need to cover here. So case number 2 is a 46-year-old female. She's had daily headaches for about 5 months. She has a prior history of migraine, though her last episode of migraine was over 5 years prior. She is obese with a BMI of 32. She has some ocular complaints, blurry vision for 1 month. She used to be 20/20, but now she's 20/30, and this does not improve with refraction. And she's also had a new symptom. She's had transient loss of vision that's lasting seconds, usually triggered by when she changes position. So if she bends down to pick something up, she transiently loses her vision, or if she's lying down, she sits up quickly, she has a transient blackout of vision. So, so you're working with a conscientious medical student who first takes her direct ophthalmoscope, she takes a look, and in the back of her eye, this is what she sees. So of course, this is quite frightening when you first may see it. It is bilateral disc edema, until it's proven otherwise, meaning until it's proven to be papilledema. But of course, in this patient, you're quite suspicious about papilledema from raised intracranial pressure. But basically, again, before you have the diagnostic workup, you cannot call it papilledema unless you're sure that there's raised intracranial pressure causing the problem. Otherwise, call it bilateral disc edema. And so, of course, in this patient, she's young, she's female. When you see optic disc edema bilaterally, you're concerned about papilledema from IIH. So that's the concern. But remember, other things can cause bilateral optic disc edema as well, not just IIH. So you want to, number one, rule out intracranial mass lesion. You want to rule out hydrocephalus. Also keep in mind, malignant hypertension can also cause bilateral disc edema. And so always, always, you want to check their blood pressure. So while the patient's sitting there in your exam room, get out your blood pressure cuff or have someone check it for you, check their blood pressure, because malignant hypertension can cause a similar appearance. Sometimes pseudopapilledema may look like papilledema and can cause bilateral disc edema. And always keep in mind that anything that can cause unilateral disc edema can also cause bilateral disc edema. For example, an ischemic optic neuropathy may be bilateral. If you have inflammation, like for example, optic neuritis can cause bilateral optic disc edema. Other types of compressive lesions, toxic lesions, metabolic, infiltrative. So there's a pretty big differential here when you're thinking about bilateral optic disc edema. But what's the workup? Well, as I said earlier, number one, check their blood pressure when they're in the office with you. And then you absolutely have to do this within 24 hours. You need to get imaging because you want to, even though you may think this patient is IIH and this has been going on a long time and this may be able to wait, you need to get imaging because on the off chance the patient has a mass, you cannot send them home and have the risk of them potentially herniating overnight. You can't do that. You need to get a scan. So ideally you want to get an MRI, but if it's not available urgently, at least get a CAT scan. Get it done within 24 hours of the patient coming in. And the main thing is you want to rule out something like this. So God forbid this patient has an intracranial mass lesion that's causing midline shift, that's causing herniation. You do not want to send them home without a scan. So anyway, I just want to mention just very briefly the Friesen grading scale for papilledema. So perhaps many of you have heard of this, you should be familiar with it. So it's a scale from 0 to 5. And I won't go through all the little details here, but perhaps you can read about it or you can go back in my slides and take a look. But Friesen grade 1, mild disc edema, grade 2, it's 360 degrees circumferential. Grade 3 is when you start to lose some of the vessels as they leave the edge of the discs, the margin of the disc. Grade 4 is when there's some major vessels on the surface of the disc that are obscured. And then grade 5 is when the entire disc, you really can't make out any landmarks on the disc. So again, this is a whirlwind tour through Friesen grading, the Friesen grading scale. So definitely go back and look at this a little bit more carefully, just so you're familiar with it. So our patient, the patient who came in, luckily her MRI was normal. She did have an empty sella, but other than that, it was relatively normal. So you're concerned about idiopathic intracranial hypertension. Just a brief review of this. As I mentioned earlier, it tends to affect young females, usually between the ages of 18 to 50 or 55. Most of the patients tend to be overweight or obese. Over 90% of them are overweight or obese or who have recently gained weight. Of course, you want to do the diagnostic workup. You want to get MRI or CT, plus or minus an MRV. If it's available to you, if there's any suspicious findings, get an MRV. And you want to definitely get a lumbar puncture in these patients to check their opening pressure and also to check their CSF to make sure it's not something else, meaning no infection or inflammation in their CSF that's causing this appearance. And in terms of the ophthalmic workup, you want to get visual fields. These are very important to help you guide your management. You're going to be looking at the mean deviation on the visual field. You want to get OCTs as well as fundus photos for baseline. And of course, the treatment, again, I don't have time in this to go through everything because I want to get to my other two cases, but first line treatment is weight loss plus acetazolamide, which is Diamox. You can also use Topamax or Lasix. And then for patients who have vision loss or have intractable headaches that are not responding to medications, you want to consider surgical intervention, whether it's optic nerve sheath fenestration or VP shunt. So that's the management right there in a nutshell. And of course, many of our patients look like this here, a typical demographic for an IIH patient. And then just keep in mind that some things may look like IIH or papilledema, but they may be something else. Foster-Kennedy syndrome is where you have unilateral optic atrophy and contralateral disc edema. So be familiar with Foster-Kennedy syndrome because it is definitely a question that comes up often on exams. And it's a case in which there's a slowly growing intracranial mass that it has compressed one optic nerve. So it's caused a compressive optic neuropathy on one side. So you see the optic atrophy, but now it's big enough to cause decreased CSF outflow. So it's probably causing midline shift. And hydrocephalus, and that's why you have papilledema on the other side. So optic atrophy on one side, papilledema on the other side. So this is something that you may see with Foster-Kennedy syndrome, a very large, slow-growing meningioma, like an olfactory groove meningioma. Then there's also pseudo-Foster-Kennedy syndrome, which is caused by, it may look like Foster-Kennedy, where you have atrophy on one side and disc edema on the other side, but this is usually caused by sequential, non-simultaneous NAION. So you have an ischemic episode in one eye that leaves the nerve atrophic or pale looking with a small cup to disc ratio, and then a swollen disc on the other side from acute NAION. So keep that in mind, pseudo-Foster-Kennedy syndrome. This can also happen with optic neuritis as well. If you've had a patient who's had optic neuritis prior in one eye and the nerve looks atrophic and then has a new episode in the other eye. So that can happen. So case number 3. Now, again, I'm going through a whirlwind here. Hopefully you can keep up. I want to just stick to my time. So I don't want to go over my time here. So this is case number 3, a 70-year-old male who has a severe headache upon awakening. He has trouble opening his left eyelid, and his past medical history is pretty healthy. He just has some osteoarthritis. This is what he looks like when he comes in. So the right eye looks pretty normal, the left eye, pretty significant ptosis. But of course, you want to lift up the lid and see what's going on underneath. So here you have an eye that is deviated outwards, and you have a pupil that looks bigger on one side than the other. Now note that this patient happens to be pseudophakic. He has a little bit of pupillary correctopia here, but this eye definitely is a bigger pupil. So this is highly suspicious for an acute third nerve palsy with pupillary involvement. So what do you do with these patients? This is a neurologic emergency. You cannot miss this. You do not want to miss this, because God forbid they have an intracranial lesion like a ruptured aneurysm that needs to be treated urgently. You need to send this patient for urgent imaging, ASAP, to the emergency department. So, so you want to get at least first a CAT scan. If you can't get the MRI right away, you're looking for acute blood that may signal subarachnoid hemorrhage. And then, of course, you want to get some kind of arterial imaging, whether it's MRA or CTA. And here we have an imaging MRA that shows a left posterior communicating artery aneurysm. It's right here. If you missed it for any reason, it's quite prominent. That's causing this patient's third nerve palsy. So just for review, just remember the third nerve, the muscles that it innervates, and the divisions of the third nerve. So the oculomotor nerve, or cranial nerve 3, is probably one of the most complex cranial nerves that we deal with in ophthalmology. Remember, it goes to 5 extraocular muscles. There are 2 divisions. There's a superior division and an inferior division. The superior division goes to the superior rectus and the levator. The inferior division goes to the medial rectus, the inferior rectus, and the inferior oblique. Also, there are parasympathetic fibers that are carried by the third nerve that go to the pupillary sphincter. That's why when the third nerve is not working, that's why you have pupillary dilation. There are parasympathetic fibers that also go to the ciliary body. So if that's not working, you're going to have trouble with accommodation. And these fibers, the parasympathetics, travel on the outside of the nerve. So they're more susceptible to compressive lesions affecting these parasympathetic fibers. So just review the course and anatomy of the third nerve, meaning the neuroanatomy of where it travels through, because this is very important. It will give you certain syndromes depending on where the lesion is. Again, in this talk, I don't have time to go through all of this, but this is a great resource. There's a book called Bahandis and Klein, which is, I believe it's called Review of Neuro-Ophthalmology, but it has some great reviews of all the cranial nerve palsies, the syndromes, the other common things that are seen in neuro-ophthalmology, meaning emergencies. So definitely, if you haven't taken a look at that book, try to get that book. It's a great study tool. But go through the anatomy of the third nerve and all the different syndromes. And again, I don't have time to go through all of the syndromes, but just be comfortable with them. There are 7 syndromes of the third nerve. In terms of what causes third nerve palsy in adults, aneurysms, about 20% of cases. Vascular disease, meaning a microvascular third nerve palsy, is about 20% of cases from either high blood pressure, diabetes, atherosclerosis. I'll also add here hyperlipidemia, which is something very commonly seen in my practice. Trauma can cause a third nerve palsy as well as tumors. And then, of course, there's this big other category of 30% of cases. Keep in mind, we talked earlier about giant cell arteritis. Giant cell arteritis can cause a third nerve palsy, either from ischemia to the nerve or to, what can look like a third nerve palsy is the muscles themselves in the orbit. So keep that in mind. So if you have an older patient with a cranial nerve palsy, whether it be a third nerve, a sixth nerve, a fourth nerve, always get GCA labs in those patients because you do not want to miss giant cell arteritis in an elderly population. And then, of course, other conditions that can cause third nerve. Zoster is something else that many people don't realize can cause a third nerve palsy. And of course, third nerve palsies can be iatrogenic after neurosurgical procedures. In children, the etiology is a little bit different. In children, most often third nerve palsies are post-viral or post-vaccination. And then there's two other unique conditions that you should be familiar with that can cause third nerve palsy in kids, which is ophthalmoplegic migraine, as well as cyclic ocular motor palsy. Now, this last one is very, very rare, but for whatever reason, it's a popular question that comes up on exam. So be familiar with it, cyclic ocular motor palsy. And then, of course, congenital palsies can happen from birth trauma, et cetera. So what does someone look like with a third nerve palsy? Well, I showed you the picture of my patient, but usually they have significant ptosis, usually almost complete ptosis, and then the eye is deviated outwards. Now, sometimes it may be deviated out and downwards, but also it could be just deviated outwards or deviated out and up. So the down is not always seen. The pupil may or may not be involved. And there you can also see divisional palsy. So for example, if you have just the inferior division being involved, then you can get internal ophthalmoplegia, meaning the pupil's not working, there's loss of accommodation. You can get lack of limitation of adduction, down gaze, and extorsion, which is because of the inferior oblique being involved. The etiologies of a divisional palsy, like an inferior division palsy, include trauma, mass, or ischemia. Superior divisional palsies are pretty rare, but they can affect the superior rectus as well as levator. So you'll see limitation of upgaze and a ptosis. So whenever you see that, you really have to be worried about an aneurysm within the cavernous sinus with inferior divisional sparing. So of course, all these patients are going to get imaging. They're going to get a workup. This is just what somebody with a inferior division paresis may look like. You see he has no ptosis and his eye is deviated upwards because that superior rectus is unopposed, but he can't adduct properly. He can't look down properly, and you see how large his pupil is here. So this is an inferior divisional palsy. Now, if you have just an isolated fixed dilated pupil, that is not a third nerve palsy. Usually there's something else that's causing an isolated pupillar dilation. So unless you have associated ptosis and extraocular muscle involvement, an isolated dilated pupil is something else, either from iris trauma, from a tonic pupil, or pharmacologic blockade. So keep that in mind. And then, of course, in terms of management, as I mentioned earlier, it's an emergency. So you need to image the patient whether or not their pupil is involved. So the old thinking was you see if the pupil is involved or not. If it's not involved, maybe you can watch them. Maybe it's a diabetic third nerve or hypertensive third nerve. But now image everybody, because even diabetics and hypertensive patients can have an aneurysm or can have a mass lesion that's causing their third nerve, and it may actually spare the pupil. So bottom line, image everybody with a third nerve palsy. As long as you explain yourself, like if let's say you're doing this on an oral board exam, you explain your thinking, it's important to kind of understand why you want to do this. And the ideal imaging would be brain MRI with contrast, as well as MRA, or a CTA is quite good as well. Next, if the imaging comes back negative, you want to do an ischemia workup. So get labs. You want to I usually get CBC with diff, hemoglobin A1C. You can get a serum glucose, cholesterol profile. In some cases, you also may want to get some additional labs. For example, if you're looking for syphilis, potentially RPR, FTA antibodies. And if the patient has if they're prone to autoimmune disease, you may want to get an ANA. Also check their blood pressure when they're in the office in case it's a hypertensive palsy. Other rare things that may simulate a third nerve palsy, myasthenia gravis is always important to consider in your differential as well. So I'm just going to skip through this because I did cover it already. So in terms of vasculopathic third nerves, the typical rule is that they recover completely, but it can take some time. It can take a few months, anywhere from 3 to 6 months, for a vasculopathic third nerve palsy to improve. And also, this is really, really important. If you see aberrant regeneration with a third nerve palsy, it is not from microvascular disease. Microvascular disease does not cause aberrant regeneration. So you either have to look for a mass lesion or you have to look for it could be traumatic. So keep that in mind. Now, finally, case number 4 in our whirlwind tour through neuro-ophthalmic emergencies. This is a 32-year-old male. He's had a mild eyelid droop for 2 days, and he also has had some neck pain. And we asked him a little bit more about his history. He said that he was just recently at a concert. He was actually really, getting into the music. So he was doing some head banging during the concert. So this is what he looks like when he comes in. So you can see his right eye looks pretty normal, the lid position, the pupil, but here his lid is down about 1 to 2 millimeters. And if you look closely, this pupil is myotic. It's the smaller pupil here. So what are you worried about? Of course, you're worried about a particular neurologic condition, but before you do the workup for that, you're going to check him in room light and dim light. And it's a little bit hard to see because he has brown irides, so it's harder to see in people with darker colored irides, but his anisocoria is greater in dark light versus dim light. So just just trust me on that one, that it's hard to see, but he does have anisocoria worse in the dark than in the light. So of course, we're concerned here about Horner syndrome, oculosympathetic paralysis. And what are the key features? Miosis of the affected pupil, mild ptosis, about 2 to 3 millimeters because of Mueller muscle dysfunction. Remember, the Mueller muscle in the upper and lower eyelids are innervated by the sympathetics. And also you can get anhidrosis of the affected side of the face. Now, some less obvious findings of Horner syndrome: upside down ptosis, meaning the lower lid may sit higher than it normally would, giving the appearance of pseudo-enophthalmos because both lids are a little bit ptotic. In the acute stage, you can see some transient dilation of conjunctival vessels because of decreased sympathetic tone. They may have increased accommodation. And they may, in the acute stage, may have ocular hypotony. In chronic Horner syndrome, particularly if the Horner's is earlier in life, you may see iris heterochromia. So on the ipsilateral side of the Horner syndrome, they may have hypopigmentation on that side. So this is another case of Horner. So here on this black and white picture, you can clearly see the anisocoria. Again, the mild ptosis on the left, a couple of millimeters, with this pupil being at least a few millimeters smaller than the opposite side. So in room light, the anisocoria may be mild, only 1 millimeter or less. But in dim lighting, the anisocoria is maximal because in dim lighting, that you would expect the dilator muscle to be working well, and it's not working well. So the sphincter muscles are kind of unopposed, and then that causes the maximal anisocoria. The other thing with a Horner syndrome is usually there's a dilation lag. So when you turn off the lights, in the normal eye, the pupil will dilate pretty quickly, but in the Horner syndrome eye, the pupil will dilate much more slowly. So this is called dilation lag, and it can take 10 to 15 seconds for that pupil to reach its maximal size. So give it some time. When you turn the lights off, don't just check right away. Give it at least 15 seconds before you check the pupil size to reach maximal anisocoria in dim lighting. So I'm not going to go through all of this because this is something really you just need to study, go back and really understand. But there's preganglionic Horners, postganglionic Horners, and there's different tests to order for each type, depending on where the lesion may be. So first order neuron can be any of these areas, second order neuron in the chest or in the neck, and then of course third order neuron closer to the postganglionic fibers. Anyway, so what you're really worried about in these patients is you're worried about a carotid dissection. And so if you're worried about dissection, definitely get MRA or CTA. In some centers, CTA is a little bit more sensitive at picking this up. And also there may be some other symptoms if there's a carotid dissection. So you want to ask about these symptoms. Is there any acute pain, particularly pain referred to the neck, to the jaw, to the pharynx, to the ear, to the cheek, or any other craniofacial location? And dysgeusia, so changing their taste may happen as well. And of course, because this is an emergency, you want to get them worked up and be co-managed with a neurologist. Hopefully a stroke specialist is on board, and these patients may need anticoagulation for at least 6 months after their acute Horners. So this is what neuroimaging may look like. So this is a case, this is actually this patient's case where there's a normal carotid over here, but here there's a dissection. So you see decreased flow, but also there's a string sign. This is the normal lumen, and this is the false lumen here. So you have a double lumen sign. And here on the axial cuts, you can also see this is the normal right side. And then on the left side, you see a double lumen here in the carotid. So these are some neuroimaging, neuroradiographic findings of a carotid dissection. So be also comfortable with pharmacologic testing, cocaine, hydroxyamphetamine, which is actually not available in the US readily anymore. And also cocaine is not the most readily available drop either. So this is the traditional teaching, is you use cocaine followed by hydroxyamphetamine. Again, go through this. I don't have time to go through this in detail, but just go through my slides or review it on your own. And then hydroxyamphetamine, which is Paradrine. And then actually clinically, most neuro-ophthalmologists have transitioned to using apraclonidine as a diagnostic test. So apraclonidine 1% or iopidine is selective for alpha-2 receptors, and it can help diagnose the Horner's because there's denervation supersensitivity at the end organ, which is the iris dilator muscle. So what happens when you put apraclonidine in someone's eyes? Well, if you put it into the normal eye, the pupil will not dilate. But if you put it into the affected eye, because those receptors have been denervated, they are super sensitive to a low dose of an alpha-2 agonist. So basically that pupil will dilate. So you get reversal of the meiosis, so reversal of anisocoria with apraclonidine. So in summary, now we're at the end of our whirlwind tour. As you've seen from these 4 cases, the neuro-ophthalmic symptoms that may occur that suggest a more serious condition may be either insidious, like we saw with our papilledema patient with the IIH, this was happening over a few months, or even in the GCA patient that was happening over a few weeks where she was having these episodes of amaurosis, or they may present more acutely, like in the case of the third nerve palsy patient or the Horner's patient. But regardless, just be aware of all of these presentations, because guaranteed at some point during your career, they will walk through the door and you will be having to do something quickly to get the patient the care that they need to help save their vision and or save their life. So again, the 4 conditions you need to know: giant cell arteritis, papilledema, either from IIH or from an intracranial mass lesion, third nerve palsy from a ruptured aneurysm, and ptosis and anisocoria from Horner syndrome from a carotid dissection. So timely management is the key. So I thank you all for tuning in. I hope through this talk, you're much more comfortable with some of these neuro-ophthalmic emergencies. I hope you're all on your way to becoming an expert in neuro-ophthalmology to take care of your patients. And I invite you, I do share a lot of great neuro-ophthalmic pearls and cases on my social media, as well as a lot of tips. So follow me on social, whether it's on Facebook. I have a Facebook group called Envision Health. You can follow me on Instagram, where I share a lot of my neuro-op cases. On Thursdays, I call it Teach It Forward Thursday. So follow me there. And then I also have a YouTube channel where I'm putting up some more of my videos, my teaching cases. And finally, if you don't quite feel comfortable with neuro-ophthalmology, perhaps you didn't have much teaching during your training, or you've been kind of focusing on other things and you're a little bit out of touch and you really need to prep. Let's say you have an exam coming up. I do offer private coaching for exam prep. So you can contact me and we can talk about whether it'd be a good idea for you to do some private coaching or not, and go through cases. Again, I used to do the mock oral exam, so I'm very familiar with how that works. And I've helped quite a few people get through their orals and pass comfortably and confidently. So thank you all for listening, and good luck to all of you in your future careers in ophthalmology. It's such an exciting time for you getting started. So thank you so much. Bye-bye.